Good morning. My name is Michiel Barneck, and today I will be presenting the outcome of immediate versus early antibiotics in severe sepsis and septic shock, a meta-analysis. Since we don't get to meet each other in person this morning, I thought I would throw in a couple of pictures of who I am. And to get things started, this research was conducted at Orlando Health in Florida. We do not have any disclosures or disclaimers for this study. It was presented at SAEM Southeastern Regional Conference in February of this year, and all of the above listed authors contributed significantly to this study. In the US, there's over 50 million sepsis cases per year, resulting in 11 million deaths. Sepsis counts for 1/3 of US hospital mortalities, and we all know that delayed antibiotic delivery in sepsis is associated with increased mortality. The landmark study showing this was done by Dr. Kumar in the Journal of Critical Care Medicine in 2006. In this study, time zero was defined as the onset of hypotension in septic patients. The authors did show that delayed antibiotics resulted in higher mortality. However, the median time to antibiotic delivery was 6 hours after the onset of hypotension, and most received very late antibiotics, many as late as 12 hours after hypotension onset. Several studies since have compared mortality and outcomes when antibiotics were given less than 3 hours versus more than 3 hours after onset of sepsis. They also found decreased mortality for earlier antibiotics. These studies have led many groups, including ACEP, AAEM, the IDSA, and CMS, to recommend antibiotics within 3 hours of sepsis onset. The Surviving Sepsis campaign and the Society of Critical Care Medicine took this one step further, recommending antibiotics within 1 hour of ED triage or sepsis onset. However, no studies have been completed to assess if there's any benefit to antibiotics delivered within 1 hour versus within 3 hours. So the purpose of this meta-analysis was to investigate just that. We assessed if there is any difference in mortality between patients receiving antibiotics in the 0 to 1 hour window, which we will call the immediate time window, versus the 1 to 3 hours, which we will call the early window. Sepsis was defined using the Sepsis 2 criteria. We also analyzed subsets of patients, including those with severe sepsis, septic shock, emergency department specific studies, and studies within the United States. This is a Prospero registered retrospective meta-analysis following PRISMA guidelines. It consisted of an initial search conducted independently by 2 authors that was reviewed and approved by a university librarian using press guidelines. Several databases were queried for studies matching our inclusion criteria, which included adult patients with severe sepsis or septic shock after the year of 2000 who received antibiotics within 3 hours of ED arrival or inpatient onset of sepsis. The intervention was receiving antibiotics in either the 0 to 1 or the 1 to 3 hour time frame, and the outcome of interest was mortality. We excluded studies that were missing exact timing, duplicate databases, pediatric patients, and non-English publications. The data was extracted by 2 reviewers. 2 other authors assessed quality of the evidence using the Cochrane grade methodology. We assessed for publication bias, heterogeneity, and used odds ratios for comparison. This is a copy of our PRISMA flow diagram showing that of roughly the 8,700 records identified, about 4,400 were left after removing duplicates between databases. These studies were then screened based on the abstracts, resulting in 242 articles that were reviewed in full text format. 229 of these were further excluded for reasons including incorrect or absent antibiotic times, no severe sepsis or septic shock cases, overlapping results with other studies, and no mortality data. This resulted in 13 studies that were included in this meta-analysis. This chart briefly relays some of the highlights. Unfortunately, not enough space to relay all the article details, just an example of data collection. 6 of the studies were in the United States. 5 were prospective and 8 were retrospective. 12 took place in the ED and 3 of them had inpatient data. In total, approximately 33,000 patients were studied. We looked at any risk adjustment between times. 5 of the studies had no risk adjustment, and 3 showed no difference in percent of patients with septic shock between the antibiotic groups. 3 had more septic shock cases in the early group. This is our odds ratio forest plot of the 13 studies, with a ratio greater than 1 favoring increased mortality with the immediate antibiotic group, and a ratio less than 1 favoring increased mortality with early antibiotics, the 1 to 3 hour group. As you can see, the combined odds ratio was 1.09 with a 95% confidence interval of 0.98 to 1.21, suggesting that for all sepsis, there is no difference in mortality between immediate versus early antibiotics. And if anything, there was a trend towards increased mortality with immediate antibiotics. However, this was not significant. Even after splitting the cases based on subsets, including ED-only cases, studies in the United States, only severe sepsis or septic shock cases, there was still no difference between immediate versus early antibiotics, with the exception of the severe sepsis cases. This subgroup actually showed increased mortality for immediate antibiotics. This is a funnel plot checking for the existence of bias. As you can see, it is a symmetric inverted funnel, suggesting that the data set is well behaved and bias is unlikely. The I-squared statistic, which shows the percentage variation due to heterogeneity, was 0.42, suggesting low heterogeneity. This is a summary of the Newcastle-Ottawa scale. Obviously, none of the studies looked at our specific outcome of interest when the study was done. As for grading, grade has 4 levels and starts at very low for most observational studies, and then is upgraded and downgraded based on the factors above. As shown in this table, our study grades as a low quality of evidence. It should be noted that most expert guidelines and Cochrane systematic reviews are graded as low quality of evidence. There's several limitations for this study. As just mentioned, the grade of the study was low given that it's observational, and there was no uniform adjustments for comorbidities or severity of illness. In summary, based on the retrospective meta-analysis of 13 studies and a combined 33,000 patients that we did, there was no difference in overall mortality between the 0 to 1 and the 1 to 3 hour antibiotic delivery groups for patients with severe sepsis and septic shock. These results do not support the Surviving Sepsis Campaign guidelines mandating antibiotics within the first hour of delivery. Because this is a meta-analysis, it is difficult to make absolute conclusions. Ours and other studies have also not taken into account drug resistance, overtreatment, side effects, delayed diagnosis of conditions other than sepsis, and cost and resource utilization. Given these facts, in addition to our results, it would be reasonable to reassess protocols demanding antibiotic delivery for suspected sepsis within the first hour. Thank you.